Welcome to today's discussion, The Whole Picture, Introducing Linked Claims plus EHR Database by MarketScan and Veradigm. Thank you so much for joining us. So I'm going to start by letting my fellow presenters introduce themselves, and I will start with Lisa.
Thanks, Nicole. So my name is Lisa Palmer, and in addition to being very excited to talk to you about this exciting new data assets that is available, I am excited to present from my purview as the portfolio leader for the real-world data research and analytics team here at Merative. I have a background in real-world data and real-world evidence generation, and work predominantly with life sciences customers as they deliver value to their customers. Next.
Matt?
Hi, and I'm Mac Bonafide. I lead up the real-world evidence function at Veradigm, which I describe as the best job at Veradigm, because my team is the first users of all the really cool data products that come out of our network EHR data. But full disclosure, I am a recovering academic. I am still getting better at muting myself. And I'm really happy to be presenting with Luke and Lisa, who I worked with for a number of years back in the Trubin, MedStat, and IBM days. Thank you.
Luke?
Yeah, Luke Belanger, I'm a director on the product management team for the MarketScan family of databases at Merative. I've been at Merative for quite a number of years, and I've been a health economics and outcomes researcher for over 25 years. Happy to be presenting some of the sort of the demographic characteristics of the database today.
And I'm Nicole Darden. I am a product manager on the Veradigm team, and we are really excited to be introducing this exciting data set today. So I'm going to start by talking about MarketScan. MarketScan is a patient-level closed claim data from over 350 large self-insured employers. It looks like from the poll, a number of you have experience with MarketScan data, so that's amazing. So this data captures all healthcare services. It spans inpatient, outpatient, as well as pharmacy claims. There includes an eligibility file, so you can really understand who did not have a service to facilitate a more accurate numerator and denominator estimates, and really assessing, maybe a lack of service. There's true cost data included here. There are insurer and patient components to that cost data, and there is detail at the procedure level. The medication and pharmacy data looks at outpatient medical and pharmacy data and includes fills at specialty pharmacies as well. And this data is applicable to all treatment areas, so it really is good for all conditions. So moving over to Veradigm, the Veradigm data is primarily ambulatory data. It is sourced from 4 of the largest ambulatory EHR products, of which Veradigm owns and operates 3 of them. This data comes from both small, independent, ambulatory physician practices, all the way up to large multi-specialty practices and everything in between. So that really gives that true look at patients across different types of practices. This data is very strong in what happens in your face-to-face office visit. So you can see here the data elements that are collected are really representative of that, with race and ethnicity and family history, a lot of those forms you fill out when you come into the doctor's office. And then the information that happens during the visit, so labs and vitals, any PROs that might be taken during that visit, as well as prescription information with sort of what the prescriber actually prescribed. You'll also see some information around medication and environmental allergies, immunization history, and current immunization. So it really is a great source. So once you put these two together, you really gain a better understanding of that entire picture of patient health to help you understand changes to health over time or impacts to specific health interventions. So it's really exciting to be able to put these two databases together to get the best of both worlds from, utilization and cost to that rich clinical information from the EHR. So you'll be able to see not just the clinical outcome or if a test was performed, but like what was the result? What was the clinical characteristics of that patient? This data is longitudinal, so it would cover, across the patient across time to really allow you to analyze patient outcomes in a unique way. And as I said, that cost data really allows for an accurate cost assessment that's invaluable for studies such as burden of illness, pricing and reimbursement submissions, and budget impact modeling. So this allows you to see sort of that comprehensive view of how a researcher might be utilizing the two different data sets. So this isn't just a all red and then all blue. We really are talking about layering in that complete picture of clinical data and healthcare resource data to better understand how that all impacts the patient and disease management. So as you're conducting your study, you may be able to pick information like maybe I need ICD-10 information here, but I want more clinical rich data from some of the SNOMED codes. This allows you to really move across those two data sets in a really comprehensive and an easy way to understand those insights. And then layering in information like disease severity or SDOH or what was that actual fill. And so that really gives a comprehensive understanding of these patients and their clinical care. So sort of to sum it all up, when you're looking at, you need clinical data along with that complete longitudinal patient record of healthcare encounters and payment, as well as that rich clinical data. This database really is a great resource for researchers. And with that, I will turn it over to Luke to talk about the population that's included in this data set.
Nicole, we have some questions. Do we want to go ahead and take some of those?
Yeah, sorry.
Yeah, no problem. So one of the questions comes in about a question around some of the lab result data and whether that includes pathology results and what kinds of results we get and see from the lab results information in the linked data source.
Yeah, Mac, do you want to answer that one?
Yeah, certainly. So remembering that our conduit is the physician that you walk in and see, we see the lab results and reports from their perspective. So if it's something they directly ordered, it might come back as like a structured field. If it's something you went out for and the lab sends it to them as a fax, yes, our practices still use fax machines, it then will appear in a different table in what we call like a semi-structured report. So the answer for pathology is it depends. We see some of it. Some of it comes through as a true unstructured field, which is harder to see. And if it comes through as an image, that's still by definition PHI. So that takes a bit more digging. So what I would suggest is kick us an email with your specific use case, and we'll tell you really quickly what the feasibility is to see if it's captured or not. But again, the things you walk in and see your doctor for and they discuss with you should be at our fingertips.
We have another question, which is around the extent to which vaccines. So Nicole, you mentioned immunizations, and there was a question about the extent to which vaccines that are administered in pharmacies are captured in the database. I might kick that over to Luke to speak to. I think we can talk to it from two perspectives here.
Okay, you can start, Nicole.
Yeah,
yeah, go ahead.
Don't everybody speak at once. Yeah. So we will see what's administered in the office, but also if there is there's some unstructured information we might get if it's completed in a different location or site. And Luke, I'll defer to you on how that gets captured on your side.
Yeah, certainly. We certainly get the, kind of the orders, the procedure codes and whatnot, and, in terms of the utilization on the claims and also obviously the payments associated. So there's a lot of great information on the claim side as well.
And to me, I think this is part of that marriage, right? Which is that we can see the information that's happening in the in-office setting, but that as as healthcare evolves in a variety of ways, and sometimes that's in the location that care is administered, the value here is that because we have that comprehensive view, we're not missing those pieces as the care might shift to another location for capturing. So I really like that. I think one more potentially quick question, and I can answer part of it and then turn it over to maybe Mac for the other part, which is a question around, one of the major values of having electronic health record data is that there is information captured in the health record that may not be necessarily a standard feed in administrative claims data, specifically around the capture around things that are maybe a little bit more directly related to social determinants of health. So race was one of the things that was mentioned in the overview. And there's a question about sort of how race is captured, whether that's self-reported, and then whether or not there are some other social determinants of health that might be captured here as well in the linked data. So if you want to take the race question, I can follow up on the others part.
Yeah, we're actually going to show some stats on that in, I don't know, 2 to 5 slides. But yes, it is captured as the physician reports it. There's categories it sits within. When we show you the stats, it'll kind of make sense. For social determinants, the combination of the claims in EHR should be pretty good capture because it's anything that's coded in a visit. One of the things we also get is SNOMED codes, which are, as I always say, a nightmare to work with, but really good for detail. And this is an area where I know on our Veradigm roadmap is to get more out of those fields in the future, specifically around social risk factors and whatnot. So yes, this should have better capture of that than you would get from either source alone.
Yeah, and I think there's also value from the family history information that you bring in and details like that. So maybe this is a question that we can revisit at the end again to see whether there's some additional things that we can parlay to the participants. I think with that, maybe Nicole, we sort of shelve the other questions until the next break and we turn it back over to Luke.
Yeah, sounds great. We could just get right into this, and we wanted to. It was great, sort of, to get the database. The database is put together to take this first look, at some demographic and clinical characteristics, and we just wanted to kind of see, kind of where things kind of landed, and a lot of things really were as expected. We see, a slight change, I guess, slightly more females are in. We did some comparisons here against the general U.S. Census. Some may argue that we're also looking at a population of people who are covered under commercial insurance. So there's a couple potential differences here, but mainly speaking, we're real pleased with these results. Slightly more females are in the link set versus the general U.S. population. You'd expect that. You see that across a lot of clinical data sets, especially. We also see it in MarketScan as well, especially as people age. The age groups are fairly similar. We see more people, as what you would expect, in MarketScan, because again, these are commercially covered folks who are from large self-insured employers. So you see a lot of working age people, so you see about a little over 70% working age people in the link set versus, what you'd expect to see a little over 60%, but that's probably pretty valuable for people looking at outcomes, especially among people with commercial insurance. We still do have sizable populations in terms of the pediatric population, as well as the seniors as well. And race, we thought, sort of landed pretty well. The overwhelming majority of people you get race data on. Ethnicity data we have for a little bit more than half, and we see sort of more non-Hispanic people in the linked data set, but what I think that was expected because a lot of the race ethnicity data are primarily coming from Veradigm. It didn't seem to surprise the folks on the Veradigm side that we saw this as well. Go to the next slide. I tell you, 200,000 contributing clinicians, that's pretty sizable. It's great to see this. We see about 65% of these folks are from, you would consider, kind of primary care per se, with pediatricians and internists and primary care physicians and so forth, but a sizable number of specialists as well, especially across cardiovascular disease and pulmonary. I was really interested in looking at the psychiatrists. There's a sizable number of psychiatrists, and you pair that up with MarketScan, where you get a lot of mental health carve-out data. There's probably some really cool stuff you can do there, adding some of the clinical content and the vital signs from Veradigm as well. So we were real happy with sort of the breakout in terms of the types of providers as well as the specialty of providers that people are getting in the link set. Next slide. We also did some key vital signs. Obviously, folks who are purchasing this data set are, really in it for the clinical content, clearly. And it's great to see, sort of all the vital signs data that comes out. A lot is really to be expected. We're getting BMI from, about 2/3, I think, of the patients, which is great to see. Again, the distribution falls as to be expected, I think. We're including the kids in here. So it's a little bit difficult to compare this to the CDC, which reports it mainly among adults. But we're seeing about 65% of people who are overweight or obese. That's in line with what you'd expect from CDC if you include the kids. So it's great to see that. I think it's pretty representative. MarketScan itself is pretty representative in terms of the BMI that we do capture. So it's great to see this pan out once we link it to the clinical data as well. And you can kind of see some of these other, blood pressure tests, obviously, and some of the more common lab results that you'd get, mainly along cholesterol here. And you can kind of see, where people fall into the high ranges and where you'd expect to see, low ranges and things like that. Next slide. And then, we did took a look at some demographic characteristics, in a couple of conditions, in terms of ASCVD, we look at the gender and, we look at sort of that age distribution. It's kind of to be as expected, I think, in terms of the ages of people who fall out here. And as well as you can see, there's even more complete and race ethnicity data as you look into this chronic condition. And on the next slide, it's similar finding for metabolic conditions. There's obviously a much more expanded set of conditions here and impacts, sort of across age groups. I would argue probably that the people who are 65 and older might have had it earlier, but we have a 6-year database here, so you can't really track the history. But, again, you can see nice age distribution, gender distribution, and again, you see increased coverage in terms of race and ethnicity within this sort of this chronic comorbid condition because people are going to the doctor more and the information has a chance to be captured more often. And I think that summarizes sort of our demographic and clinical characteristics section. So I'll turn it over to Mac and Lisa.
So Luke, I'll ask some of the questions that have come through in the chat and
Sure.
put them through to everyone on the panel. I think there are some general questions about like how the linked MarketScan Veradigm data sausage has been made. And so there was some questions about how the data are linked, what is the size of the linked database, and just some information, a little bit more information about the types of ambulatory care practices that the Veradigm data is sourced from, and the types of employers, if we know that information, that the linked side of the MarketScan data comes from. So I think those are questions for a variety of us. I don't know, Nicole, if you want to start from the Veradigm perspective. I can certainly kick it off by offering that right now, someone will have to keep me honest on the years, but in the last 6 years of data, I believe there's a little bit more than 8 million linked patients. So it's a nice, robust sample over a relatively short period of time that those individuals are linked. Both organizations have access to and the ability to link deterministically. So these are not probabilistically linked. So if Lisa Palmer is on the MarketScan data, and Lisa Palmer is also part of the Veradigm EHR database, that you are getting me for sure in both data sources. But Luke, can you speak a little bit more maybe about sort of the types of employers that are contributing, and then maybe Nicole on the types of ambulatory practices that are contributors?
Yeah, I can speak. Certainly, the overwhelming majority of market scan patients that we do have secondary use rights to link do come from the large self-insured employer contributors for sure. And so, overall with MarketScan, we can link about half of the database, but if you look amongst the large self-insured employers, it's a much higher percentage. And so that's great because that offers, sort of all the benefits in terms of the longitudinality and the payer mix and so forth, and the actual cost that Nicole talked about earlier. And so we can certainly look by industry. I don't have that, but that might be a future demographic slide. We can kind of break that out.
Yeah, and then on the Veradigm side, like I said, there are 4 different EHRs that are contributing that each have their own sort of EHR practice profile. So, we do have large ambulatory multi-specialty practices included, as well as those small, maybe 1 doc, 2 doc physician practices as well. I believe that, we have a good mixture of all of them. And Mac, I don't know if you have any specifics in terms of like percentage breakdown between small, medium, and large. I don't have that on the top of my head.
No, we don't, but we know it's a very good spread. I mean, each of the EHRs has a legacy of what they were focused on. So bringing them together gives you a good comprehensive spread. We have single physician practices in our network, and then we've got multi-specialty that are 50, 60, 70 physicians. And we've got all the other folks that are using the EHR, whether it's the nurses, the admins, and whatnot. So it's a good range, and we do know that it looks like good coverage across the United States. There's some of those things there's some geography things we have to mask from the StatCert perspective to keep the certified de-identified. But we know that both databases have good national coverage, and we know the link does as well.
So a couple of follow-ups I think we might have time for before we get into the VMI case study. Again, some of these relate to sort of the organization of the data, specifically around sort of how the data are organized and how the data has been structured to ensure that users of the data sort of understand how to create a singular patient journey and sort of work with the potential of duplication of activities or services, given that they're being reported in both databases. I don't know if there's someone that wants to jump in on that one. I do the default.
Some of these, I would love to. So we do a lot of work on vaccinations. In our data, because a lot of that happens in the office. The conversations happen in the office. The education happens in the office. The education to counteract the miseducation outside of the office happens in the office. So that really gets to the protocol. Like, if you want to count, healthcare resource utilization, how do you ensure that if I see the visit in the EHR, am I counting that and I don't double count it in the claims? At the same time, I would love to see, I like to see an event in both databases because it lets me look at a thing like a gap. So if a physician says, go get your COVID shot, and they document that on a Monday, well, did you get it? Where did you get it? When did you get it? What did it cost? Those types of things. So making sure if that happens on the Tuesday or the Wednesday, or even that same Monday, we don't count it as 2 events, but that becomes part of our analysis. But to me, that's very much we at the data factory side of the thing is not going to impose any rules that prevents you from seeing that. We'll help you once you are using the data. We'll work with you to say, here's our best practices. Lisa and I have pages and pages of SOPs. We'll tell you how we would handle it, but we wouldn't want to force our decision upon you. That's very much a protocol question, yeah.
Well, and I think that wasn't the answer I thought you were going to give, because the answer that you often give that I think is really valuable is that we haven't forced a new structure, an entirely new structure, into the linked data. So one of the reasons for the poll at the beginning around the familiarity with MarketScan or Veradigm or both was in part because a lot of the native structures to the databases that you might already be familiar with are we've retained. And so to Mac's point, if you're familiar with Veradigm and their nomenclature and variable naming, then a good amount of the link data will look very familiar to you. And same thing for the MarketScan side. So you will see the opportunity to find that thing as it is observed and reported on the Veradigm from the Veradigm data input side, but also that thing in the way that it's reported from the MarketScan side, and then to Mac's point, make a determination about how you convert the value of that into your analysis. One more question maybe till we go into the BMI case study, which is around the data availability and refresh schedule. So I'm assuming that this is coming from folks that are maybe familiar with the MarketScan. The MarketScan refresh schedule vis-a-vis sort of what that might look like from the Veradigm side. So maybe we can speak to what that looks like for the link data.
Yeah, so the link data is available today from Q1 2018 through Q3 2023. We are planning on a quarterly refresh schedule, so that's the cadence in which we'll be refreshing it.
Thanks, Nicole. I do want to note that as people can probably see in the Q&A, there are a lot more questions than what I've been sort of putting forward, and I'm doing my best to keep up and sort of retain some for the end. So if we don't, as Nicole mentioned at the start, if we don't get to your question at all during the presentation, we will definitely follow up within the next day or two, but we will also retain some time at the end to go through some of these questions that we're not getting to immediately as well. So with that, I will turn it over to Mac to go a little bit deeper into a BMI case, some BMI examples.
Yeah, thank you. So I'm going to talk to you a very brief use case from kind of the budding stages of this collaboration. We started out posing a couple of really high-level questions that kind of focused on joint data elements, something that we each brought to the table. But before I do that, I do want to thank a colleague of mine, Corey Pack, who ran all of the analytics you're about to see. My days of programming in Stata are long behind me, so thank you, Corey. We wanted to carve out like a little corner of this cool data sandbox. So what we did is we kept it simple. We picked adults with continuous enrollment in MarketScan for at least any one calendar year from 2018 to 2023. So patient can appear a bunch of times, but they have to be there for all of at least a year. And we said you had to have a valid BMI in at least one of those years. And then we ran a bunch of summary statistics around them just to explore the relationships, so just to explore what we're seeing between these different demographic measures and then total annual costs in a given year and BMI. Again, by definition, these are patients who had health plan enrollment for an entire year in MarketScan, but they also had to have some EHR activity in the EHR in that year, if that makes sense. So they had to do something to get the BMI captured. Again, at the protocol stage, maybe you relax that a little bit, use longer history, but just for this purposes, we kept it at a year at a time. Again, this is cross-sectional. This is not longitudinal. We didn't do any high-level stats on here. This was just a chance for us to have a little fun with the data. So at a high level, we had a really good distribution of sex, age, and race in the combined data. It's important to note that race is not a required field. So just under 1 in 5 patients had an unknown race. It's also important to note that other is actually a valid category. It includes patients who fall into more than one category who specify something else that isn't in the stats cert. So about 1 in 5 had unreported, uncaptured race. In a minute, we'll show you total costs split by BMI across these categories, but these pie charts gave me some reassurance that we could dig into subgroups of interest. We could dig into racial and ethnic subgroups. We could dig into age and gender subgroups, and have all the different combinations of them. We had good representation. Next slide, please. Okay, I was surprised to see this. I was surprised that our BMI was actually pretty steady across years, within like a half a point there, right around 29. If we kind of start in the far left in the upper right-hand quadrant of that pie chart, about a quarter of our patients had a BMI of 18 to 24, about a third were 25 to 29, and around 1/5 were each in that 30 to 34 and over 35 range. So it's important, for the purpose of this, we kept it to patients just above a BMI of 18 for this analysis. We do have to cap BMI at 40 in the data to maintain de-identification. There's a couple other things like that that have to get scrubbed out. Publicly reportable accidents, if you're in a plane crash, stuff like that has to get scrubbed out of the data from a stats perspective. On the right-hand side, you can see where we start to dig into the total annual costs by BMI category. So we show total annual costs for each of these BMI categories. Lisa's going to go into this in more detail in a minute. But what's really cool is you could see this consistent kind of ladder-like relationship across all of the study years. Very, very, very consistent. Average annual costs for approximately $16,000 a year. So you can get a sense of kind of the increment within each category. So going from that 18 to 24 category to either the 25 to 29 or the 30 to 34 category is associated with about a 9 to 11% increase in average annual costs in any given year. However, when you go from that 30 to 34, when you go up to that 35 plus, that's where your total costs increase by about 20% in any given year. So again, full disclosure, we didn't perform any statistical tests in this, but it matches what we've seen elsewhere, and it gives us a sense of the sandbox that we can dive into in much greater detail. And I know, Lisa, you're going to take it from here and dig into some more specifics on this.
Yep, sure thing. So as advertised, we're looking now sort of at annual costs by different cuts of the data. And rather than focusing on sort of the specifics here in terms of like the dollar increase for this or the dollar increase from that, what I really wanted to focus on here is simultaneously some of the sort of preliminary and interesting findings from what we looked at, but then sort of getting people to think about sort of beyond what we're maybe specifically reporting here, and what that means about sort of the value of bringing these two data assets together. And so, as Mac mentioned, maybe not surprisingly, you see there's some consistency in terms of sort of the BMI over time and sort of the relationship that you see here, but maybe unexpectedly, you see that the overall costs here are increasing as BMI increases. One of the things that I will note for the next 4 panels is that at this point we've reported total annual costs. These are not adjusted for other comorbidities. They're not adjusted for inflation or anything of that nature. But you do sort of consistently see this increase, as you might expect, that as your BMI goes up, that the cost to sort of care for you over time or over a period does also maintain that same relationship. One of the things to remember here is that if, for those of you on the call that are familiar with MarketScan, you will remember that in addition to being able to report annual costs, you are able to break down these figures. So you could see sort of future iterations of these kinds of reports being able to be done based on where and the types of services that are generating these costs. So you can sort of do those service category distinctions that you can do now using your MarketScan data. So breaking this out to see whether there are differences while the overall and total annual increase distribution looks this way. Is that different? And do you see shifts in terms of the proportion of cost that is coming from different types of services, inpatient, outpatient, emergency room, and prescription drugs, and whether that shift sort of also reflects sort of this similar trend as you evaluate these by BMI. And we also sort of see here that being able to overlay some of those demographics. So there had been a question about race. We've sort of demonstrated a couple places about being able to look at patient race. But you can see here how being able to include information like patient race really sort of fills out the narrative that you maybe are trying to build, or identifies the places where you may be wanting to target some of your research, because sort of the impact here is somewhat different as you look at some of the racial categories. So in this case, there is sort of some marked increase in terms of sort of the costs that we see for particularly patients who have been identified as Black in the database, and what that means for sort of maybe how you do your analyses or how you think about targeting your product or your messaging can now be, sort of better constructed now that we have these data married together. Next slide. And I think similar to what I sort of spoke about in the previous slides, sort of the general nature, right? So you can look at it by male and female. You can look at the different age breakdowns. I was interested to see that, sort of overweight and obese men actually cost more than women, because that wouldn't have been what I necessarily sort of would have considered. Again, unadjusted, but it wouldn't have been what I would have guessed had you asked me initially sort of what the trends look like. I think, also maybe not surprising in the unadjusted framework, older patients sort of consistently, the who costs more sort of trends are reflect maybe what you would have thought were true as it relates to BMI, and maybe what you thought would be true as it relates to age. And those are sort of consistent here. What I really want people to sort of start to think about is that the reason for what we were presenting here, it wasn't necessarily to really get down in the weeds and do a full built out analysis around cost and some of these metrics, including BMI, obviously. But the idea here is to really show how the marriage of the two data assets with some of the information that is unique from the Veradigm side, in this case, having access to BMI, and some of the pieces that are unique to MarketScan, which is having the cost information, can really start to evolve the types of analyses that you might be thinking about and might be executing. So even people that are not interested in BMI, but might be interested in other clinical measures, you can start to see a pathway where being able to analyze the data with an eye towards things like looking at the cost per unit increase or the cost per unit decrease, and what that looks like, so that you can start to really create really nicely rounded value messaging for around things that include a measure of severity or a measure of issue related to some of the clinical measures that we're able to integrate into these data. So Matt, I will pass it back over to you.
Yeah, and I think that's a great way to put it. Is we've got a really good, really clean combined data set that has fidelity back to the native data, the native data sources and formats. So what can we do with that? So this is like digging one step deeper, and then I promise I'll go back on mute where I belong. We looked, as Lisa was showing, we looked at average annual cost as they increase with BMI, but here we wanted to dig into, MarketScan has really good, clean, it's the gold standard for cost data and cost composition. Where did those costs come from? The table structure tells you what type of cost it is. So we looked at some trends. So what we actually saw was with increasing BMI, obviously we saw total costs go up, but we saw a disproportionate increase in outpatient pharmacy costs. So if you go from, just picking 2 points, if you go from 25 to 30, it's about a 9% increase in inpatient costs, 12% increase in outpatient costs, but a 20% increase in outpatient pharmacy costs. If you go from, up to 35, those numbers are 23, 20, and 40%. So a 40% increase in your outpatient pharmacy costs. So it's going up faster than everything else as BMI increases. So the reason this is interesting when Lisa starts to talk about what happens over time, what are trends? If you reduce your BMI and you bring down the cost, where does the composition cost changes? And it'll be fascinating to see how this plays out in the GLP-1 wave. So kind of in wrapping this up, I hope you can see kind of our excitement about having the sandbox to play in. Lisa's team and my team are really excited to build out internal analyses like this, questions that we just want to answer because they're fun to answer and play in the data. If you have questions, obviously there's a lot of questions in the chat that we'll get to in a few minutes here, but if there's questions that you'd like to see answered, drop us a line. We love talking about this. We'd love to explore these ideas with you now that this is available. And now, Nicole, I will turn it back to you to wrap things up.
Oh, but you're always wrong because it's always me in the middle.
Oh,
I was going to say the meat, but I'm not sure that that's where I want to go. Um, so a couple of questions that probably relate a little bit to our section, Mac. One was about, is the cost information available for charge costs, paid costs, or both? And so for those of you that are familiar with MarketScan, it follows a similar to the MarketScan, MarketScan licensed products, that will be the paid costs. And that will include not only the portion of the costs that was paid for by the payer, the employer, or the payer, the primary payer, but it will also include the costs that the individual patient is responsible for. So that will include things like deductible, co-insurance, and co-payment. For the individuals in the database that are also dually eligible for Medicare, you will also see the payment portion for the Medicare coordination of benefits piece included in that. We also had some questions, sort of general questions, Mac, about like what is included in the, like what I'm going to call the lab data. And I think we can sort of extend that to mean like sort of when you think about LOINC coding and what we include in the linked data as it relates to LOINC coding and lab data, what does that include?
so it does
And so
include
just to hop in really quick, sorry, I did put up the sort of the category, the features that are included, which gives a little bit more detail to some of the pieces, Lisa, that you're speaking to. Sorry, go ahead, Matt.
No, exactly. And that's a good call out. So it's stuff that doesn't necessarily only travel as a loin code. It's heavily loinked, if that can be verbed. There's also a lot of vitals and stuff that travel in there that, for example, your LDL has a loin code, but also if we get it from other means, it doesn't come back to us as a loin code from like a request or a LabCorp back to the practice. We have that in there as well. There's a lot of questions in the chat about, can you do this in this therapeutic area? Can you do disease staging? And the answer is always, it depends. We have the physician you walk in and see, we have everything at their disposal for what they know about you and what they've documented. So we always want to run like very study specific counts on this. Unfortunately, we're often disappointed in what gets captured in the encounter. We find that a lot of people don't get the labs that got ordered, or don't get the follow-up visit to discuss those labs after they got ordered. So it's really context specific for what we're able to do. What we do say is the things you see here, the things you walk in and talk to your doctor about a lot: cardiovascular health, metabolic health, mental health, whether that's depression screens, anxiety screens, stuff like that, is going to be well captured in there because it's the things at your physician's fingertips for that encounter that they have with you.
Thanks. And there was another question also about sort of which MarketScan data were included in the link. And so I think as you may have inferred from my reference to Medicare, it includes the MarketScan commercial data, which would be the commercially insured individuals who are still sort of working age, if you will, under 65. It also includes the Medicare data that we have. And then this is where I'll need like some fact checking. It also includes our MarketScan lab results data. And so as it relates to the question about sort of the lab question generally, for those of you that think about this, what this means is that in addition to enriching the MarketScan lab data that we have, which means that individuals who were historically in the MarketScan data that were not part of data contributors that provided us with lab results, that we will now have lab results for those individuals. It means that for individuals that maybe were in the data and who did get some lab results generated, that their lab result experience is now enriched from additional lab results coming from the Veradigm side. And it means that you're at, that net new patients. But one of the things that I always think about is that in the MarketScan lab data side, if you're familiar with that, you're probably a little bit more accustomed to getting the routine blood panels and urinalysis of results. Matt talked about some of the things that you think about as it relates to PROs, but also sort of the swabs are the things that I sort of just never even thought about when we talk about lab results. That is sort of one of the features of what we'll be integrating as well. So it won't just be sort of routine blood and urine per usual. It'll be routine blood and urine, swabs, and some of these enrichments, including things coming maybe more traditionally from a patient report or clinician report perspective.
And to answer the one question, it is definitely available for direct access and being licensed, which a lot of our effort in getting this in front of folks was to maintain what we wanted, our native data elements, our native data models, the data fidelity back to the sources. So it is not something you've mushed into a model somewhere between Veradigm and Merative, but it's really honoring the true sources, putting it out there in a compliant way that you guys can access directly. You're stuck with us either way. If you have questions, you're going to end up back with me and Lisa to kind of figure out the best tips and tricks, but it's definitely usable.
So I think, Nicole, we can sort of take it to sort of maybe more general questions, and I can certainly sort of start to work through those. I think there are some that fall into themes. So maybe I'll start by identifying some of the themes that I've sort of noticed, and we can take it from there. There were some questions about some follow-up questions, which I will blame myself for, on sort of how the data were linked together. We do use, both organizations use the Datavant tokenization process. So this wasn't sort of a homegrown in-house process of linkage. We did, in fact, go through Datavant for tokenization. And obviously what that means is that as it relates to which MarketScan data sources are included in the linked data, it does require that we use those sources for which we have the secondary use rights and the around the identifiers that can be used to generate those tokens. And so, as I mentioned, right now for us, that is the commercial and Medicare population. It is not the Medicaid population. There were also some questions about sort of tangential things, and I did promise earlier on that we would sort of circle back to this. So there's sort of questions around the ability to expand maybe the core off-the-shelf product and what the available licensable data includes. So there were questions, for example, we had the question about additional social determinants of health, including things like education and wage or salary information. I saw some questions around mortality. And so the question or the answer there is that, while we do have a version of the product, and I'll maybe turn it over to Luke and Nicole to speak a little bit about what that looks like in its stat-certed way. We have a version of the product that includes many, many, many of the elements that you're familiar with from both data sides, but maybe doesn't include all of them given the statistical certification requirements. There are things such as mortality, zip code level linkages to things that might fold in additional social determinants of health information that are not necessarily part of the off-the-shelf product, but we do have the ability to extend your research by integrating those on a sort of a case-by-case research basis that one of our research teams can execute on your behalf. So as Mac mentioned, the best approach in those situations, if you have a specific question or need about some of those extras, would be to reach out to your account executive or your friendly Veradigm Merative person and and get them to sort of help you walk through like the art of the possible in those situations. I don't know, Nicole, do you want to start on the like, great, what did I have to give up to get this super awesome data set?
Yeah, you actually already hit on it. For the most part, within the Veradigm data, what we were required to redact as part of the stat cert was some of that more detailed geographic information. So that's the biggest area that we had to work around for the stat cert. And Luke, I don't know if you want to touch on what on the MarketScan side.
Yeah, it's for those of you that are familiar with MarketScan, we do have geography down to the MSA levels, CBSA level, some would say, in the standard version. This version is at the state level, from what I recall, in terms of geography. So a slight uptick in the geographic granularity, and also we were not allowed to include the family related variables. So things like we have an encrypted family identifier and family relationship variables. So those were the two big areas. There's probably some minor ones, especially around place of service that we were asked to clean up. But that's pretty much what it was.
Thanks. There was also sort of some questions about the key differentiators that we would position here. I might take a stab at one or two and then let the rest of the panel like weigh in on. I'll try not to. I'll take one maybe. I think one of the key differentiators that I see here is really sort of that from both sides of this equation, you are getting the data directly from the data originators. And there is tremendous value in being able to sort of source your data from the people who build it and know it best. And I think that parlays into sort of the quality of the product that you're getting, the ability for you to have the support that you need to be able to use it efficiently and correctly and all of those things. But I think, there's value in birthing the child from each of the native parents here in that way. I don't know, Luke, if there's one that you would highlight.
Yeah, I mean, it really goes back to the sourcing of MarketScan, that I like to talk about in terms of the strengths. There's some products out there that are available that link together claims and EHR information, let's face it, and there have been for years. The great thing about linking a great clinical source like Veradigm to MarketScan is the completeness of the claims. Keep in mind how in terms of the sourcing from the sort of the individual large self-insured employers. We have very complete information. It's very research grade, publishable, multiple, obviously, heterogeneous kind of payer mix. And then there's the actual cost part. It's very difficult to get actual financials, to kind of take a look at, across sort of different diseases. And now that you can kind of, you can sort of specify the severity of the disease in a lot of ways using the clinical data. You can do a lot more, really powerful studies with it. So I'm really excited about it.
Nicole, Mac?
Well, I like that the perspective we brought to it was you can either think of it as a joint database, it's all there, or you can say, well, I'm a claims researcher who wants to go into more clinical depth, or you can say I'm an EHR researcher that wants to get more breadth and figure out what happens outside of my practices. We put a lot of thought into the structure and approach to let all of those perspectives kind of cohabitate on the same call. And a lot of thoughts back to the data fidelity, a lot of trust that the data is rock solid and excellent and well established and well used in maintaining that native format and approach as much as possible to bring any of those three perspectives to a project. That's what I'm most excited about.
And I'll just finish it up by saying, I think as you saw many of those slides, we have a good representation from small to large practices across insurance types. So I think we're just really excited with the really unique data set that we're bringing to the market here.
Thanks, Nicole. And I think we're going to turn it over to the admins for final wrap up.
I think that's just me.
Oh. Other hat.
Yeah. So I will just land on this slide. I think we covered a lot of this, but just to really drive the message home, many of you from that poll have some experience with either one or both of these data sources. You know that this is a really great source from the data originators. So with that granularity to address all these complex research questions. This also speaks to our research grade data that we're bringing to the table across both the EHR and the actual cost and standardization from the claims side. And then the representativeness, multi-payer source, diverse benefit structure, as well as the largest ambulatory network of EHRs. So we're really excited to start fielding your questions. And as I'm just going to steal blatantly from Max, since he's right here, we want to hear what keeps you up at night. What are the research questions that you want answered? We're really excited to start digging into those questions.
We thank everyone for joining today, and we look forward to being able to go ahead and start exciting work with you. Thanks, everyone.
Yes,
Thank you.
Thank you. Thank you.